Good afternoon, everyone, and welcome to Member Café. We are just going to wait just a few moments to let everyone get logged in before we get started. All right, so good afternoon. My name is Ann Gluff, and I am part of the member engagement team here at Partners Health Management. And we are so happy that you decided to join us for Member Café today. So before we get started, I just want to introduce a few folks to you. Beth Brooks is here with us along with me. She is also a supervisor here in member engagement like myself, and she is our behind the scenes Zoom guru, and she's just going to make sure that everything runs nice and smoothly as we move through our hour together today. And then also with us is Melissa Hatton. She is member engagement specialist, and she is going to be dropping some great information into the chat for you so you can grab it and copy and paste. Just makes it easy for you to get that information. And Allison Crotty, she is Senior Director over Member Services. She is joining us here today as subject matter expert. And Dr. Bartholomew is here. She is our guest speaker, and I'm going to tell you a little bit more about her in just a few moments. And so while Beth is pulling up our slide deck for us, I'm going to just go over a few housekeeping rules. So here we are. Welcome to Partners Member Cafe. So for those of you who are new to Partners Health Management, we are a managed care organization for North Carolina Medicaid and other state-funded services, other state funds. So we are charged by the state to manage those dollars to support individuals with Medicaid and those who are supported by state funds for behavioral health services, those services that support individuals with mental health needs, intellectual and developmental disabilities, substance use disorder, traumatic brain injury. So again, a few housekeeping rules. This meeting is being recorded, so you want to be sure to not share any information about sensitive information about a family member. If you want to speak with any of us here at Partners, you can do so by reaching out to our member engagement team. We're going to share that contact information with you, and we can set up a time to talk directly with you about your family member. One of the things that always gets asked is, will the slides be available? And the answer is yes, the slides will be available after the event. We are recording, and this recording will be posted on our website for you or anyone else to view. Give us a little bit of time, about a week or so, to get that posted. During our session today, I want to encourage you to enter questions into our Q&A. Our guest speaker is going to do a presentation, and I know a lot of times when you're listening to a presentation, if you don't get to answer that question right away, you might forget it. So feel free to drop it into the Q&A. The chat is disabled for you to write into it. We can chat out to you that information that Melissa's putting in for you. But if you want to enter a question, please enter that into the Q&A. You can also, when we get to the Q&A time period, you can raise your hand using the reactions feature at the bottom of the screen. You'll see a raise your hand. And at that point, we can open your mic for you so you can speak. All right, so what I'd like to do right now is introduce our guest speaker. So Beth, if you want to forward your slide just a little bit to the next one. So today, Dr. Neva Bartholomew is going to talk to us about common medical risks for people with IDD. And let me just tell you a little bit about Dr. Bartholomew. So she tells us that she is a Tar Heel through and through, and a native and graduate of UNC several times over. Undergrad, medical school grad, family medicine residency, and public health school. She's lived in Chapel Hill for several years and has over 25 years of experience as a primary care physician, with the majority of that time spent caring for the most vulnerable citizens of our state, including in the health departments, state psychiatric hospitals, and prisons. And she is the proud mom of 2 girls, ages 22 and 19. Her youngest daughter has a significant medical and developmental issue related to a genetic syndrome. She wanted to let you know that she's very excited to work here at Partners, where she can use both her professional and personal experience to encourage whole person care and improve lives on a larger scale. So I'm super excited to introduce to you Dr. Neva Bartholomew. So Neva, I'm going to let you take it away.
Thanks, Anne. Thanks all of you for inviting me. I'm thrilled to be here. This is a topic near and dear to my heart. If you want to advance the slide, Beth, I appreciate that. You've already gone over all of this, so I won't bore you with this again. The main thing I wanted to make sure that you got from that was that I'm a mom, and that is the most important role and important job, and probably the hardest job. In fact, I know it was the hardest job and still is that I've ever had. These are my girls. You already heard about them. They're 19 and 22. The one on the left is Meg. She's the 19-year-old. And that was a recent picture on the left there. And then the one on the right is a picture of both of them when my older daughter started to learn how to drive. And it was a thrilling moment for us, not just because she was more independent, but because my youngest daughter loves to ride in the car. So this was an opportunity for them to hang out together, listen to loud teenage music without us, and enjoy some sister time. So I love this picture for that reason. So we can move on. Just to sort of level set and make sure we all know what we're talking about here, an intellectual or developmental disability is a severe long-term disability that begins before the age of 22 and affects cognitive and or physical function. The number's a little bit hazy, but we think about 7 million people in the US have IDD. We know that they have higher risk of medical and psychiatric conditions that cause early death. And what we also know is that those deaths can be prevented. Many of them are preventable by recognizing the risks that folks have, treating those risks early, and addressing the disparities, which means the differences in healthcare between this population and the rest of the general population. So the next slide tells you a little bit about the disparities. So disparities may be a new word to you, but really it's just the differences between, like I say, one population's health and another. And the way we know that there's disparities is when you look at some of the data, you see that folks who have IDD have a lower rate of preventive health screening and vaccinations. That probably contributes to the fact that they have a higher rate of different diagnoses, certain nutritional deficiencies, obesity, diabetes, heart disease, arthritis, and asthma. Those are just a few. They also, as you probably know, have a higher rate of behavioral health issues and get prescribed a lot more psychiatric meds than the general population. We know many folks who have IDD also have an earlier onset of dementia as they get older. This is a really important one to mention, and one that I think we don't talk about a lot, is the experience of what we call diagnostic overshadowing, which is a new term that I recently learned, but you probably all experienced it or know what I mean by this. It means when a medical provider has not worked in this population before. And I'll just tell you as a doctor that we don't get any training with folks with IDD. We really don't. We may have some folks that we see here and there, but no one tells us anything special about them or helps us understand how they might be different. So oftentimes when someone comes in who has IDD and they have a new problem, we tend to say, oh, it's related to that. For instance, there's behaviors that are new. Oh, well, that's just how folks with IDD are. So that's what we call diagnostic overshadowing. It's missing the diagnosis because you want to attribute everything to the IDD problem. A real issue that we probably don't acknowledge enough. Unfortunately, all these disparities lead to a lower life expectancy. Again, the numbers are a little bit hazy, and it partly depends on what the primary diagnosis is, or what the cause of the IDD is. But we think that on average, these folks die about 20 years younger than the general population. And like I said before, they're more likely to die from preventable illnesses that we could make a difference with. So let's move on to talk about what those preventable things are. We call this the fatal 5. Years ago, it started with the fatal 4. We added a 5th, and now we've added another one, but because 6 doesn't have an F in it, we're calling it the fatal 5 plus. So these are the fatal 5 plus, and I added one more. Constipation, which leads to bowel obstruction, aspiration, seizures, dehydration, GERD, which stands for Gastroesophageal Reflux, sepsis, and then I think you can learn these, but what you really need to know is how to recognize them. You can memorize this list, but if you don't know how to recognize them or how to get help when you need it. So you recognize this problem, but how do you get doctors, healthcare providers, other people to understand when there's something to be concerned about? Okay, next slide. So this is the first one, and I put this first on purpose because I feel like this is the most common one we deal with, and also the one that you probably deal with every day in some way, shape, or form. It's also the most common cause of preventable deaths of people with IDD who live in communities, not institutional settings. We know that people who have autism, cerebral palsy, other neurodevelopmental disorders related to their IDD certainly have more trouble with their bowels. We're not, a lot of that is neurologic, that the brain and the bowel are very connected. So if you have an issue with neurologic functioning, those nerve endings in your bowel are also affected. Now, so it's sort of unfortunately a setup for problems to begin with, but then we make things worse by adding medications oftentimes that are constipating. We also sometimes make things worse by the diet we eat. Low fiber diets, which is a lot of the processed foods we eat are low in fiber, fast food, very low in fiber, not drinking enough, really big issue for many things, but definitely for constipation, and immobility, which a lot of folks are not moving enough, me included, because I sit in front of the screen all day. Now, most of us would know if we're having constipation, but sometimes it's hard to identify if you have IDD. Often it's because the symptoms are not as obvious. Maybe folks are not able to express that. Different people are helping them with toileting, or they're not aware of the toileting. Perhaps someone's very private. So you may find that the symptoms of this are unusual or not what you're expecting. One of them is pain. Of course, that's a little bit more obvious, but some folks show their pain in different ways. They suddenly have more behaviors, maybe more self-injury, maybe just more irritable, maybe avoiding people. Behavior is communication. So if someone has a new behavior, it's probably because something is going on there they are trying to express. New urinary incontinence. You may not think of that as caused by constipation, but when you have a lot of stool down there pushing on your bladder, you tend to leak more. So when someone develops new urinary incontinence, one of the first things we need to figure out is, are they constipated? Fever. I know it's strange, but constipation can cause fever, and more so in older folks or folks with IDD. And then this is another tricky one. We often see this in the many years I worked in the state psychiatric hospital. I would see, get calls that people were suddenly having diarrhea. And these are folks who had longstanding constipation. So it didn't make a lot of sense that they were having diarrhea. What they really were having is blockage and then liquid stool going around the blockage. So oftentimes the knee-jerk reaction to loose stools is to stop with all of the laxatives or stool softeners, when really it's the opposite problem that needs to be dealt with. So these are tricky. Once somebody has constipation and has it for years and years or months and months, and it's not getting better or we're not treating it well, it can cause long-standing problems because the bowel tends to get kind of sluggish and lazy over time. And the more it holds, the less it works. So it can lead to what we call impaction, where you've got a blockage. That can lead to this chronic soiling, which some of you may have experienced with folks, where they're just constantly leaking stool because their bowel just doesn't hold very well anymore, or it's so overfull that it's leaking. Of course, hemorrhoids and problems with the rectum, where the rectum prolapses out, where it pooches out from all the stress, and also obstruction, which is the primary reason for death from constipation, is eventually it can lead to obstruction, especially if obstruction is not recognized quickly enough. Next slide. So this is just a list of common medicines that are constipating. You probably know a lot of these, but maybe not. Opiates are a big problem for constipation. Hopefully a lot of our folks are not on opiates, but if you happen to get added an opiate after surgery or tooth pull or something, just be very aware that that's going to constipate folks. Antihistamines, that's things like allergy medications, Benadryl, they dry you out. That's why they work for allergies. So they're going to dry out your colon as well. Diuretics are similar. They make you pee out extra fluid, which makes your colon not have enough fluid, which makes your stool hard and impossible to pass. Anti-incontinence medications are some of the things we take when somebody's having problems with holding their urine, and they have the same kind of antihistamine properties. It's actually called anticholinergics that antihistamines and anti-incontinence medications have, and what they do also is dry you out. So if you've ever been on, say, one of the, I'm trying to think right now, one of the names of them, but the bladder medications, you'll notice you get a dry mouth. Dizipramine, those kind of things. So blood pressure medication is another one we don't often think of, and it's not all blood pressure medications, but there's one called amlodipine, which is Norvasc, is particularly constipating. Anti-nausea medications can sometimes do it. Iron is particularly bad, especially at high doses, both for upper GI symptoms and constipation. And then several antipsychotics, particularly clozapine, olanzapine. Most all of the second generation antipsychotics are constipating. Those are the newer ones. And certain classes of antidepressants, like the tricyclic antidepressants, like Elavil, which is sometimes used for pain, it's particularly constipating. You can go on to the next slide. So what can we do about it? Well, first of all, I would be forward thinking and try to prevent it if you can, because once you've gotten to chronic constipation, it can be very hard to turn it around. So thinking ahead, thinking, especially if you're adding a constipating med, you may want to start something new along with it. Eating high fiber diet, which we all should do. So that's real whole foods with lots of fiber in them, like vegetables and fruits. Whole grains, not white flour, not white rice, but brown things that you can see the seeds in. They will give you more fiber. Drinking lots of fluid, and we'll talk about that a little bit later when we get to dehydration, but definitely very, very important for constipation. You may have seen these ads for the squatty potty. But that's basically a footstool that you put at the end of the toilet. And what it does is changes the angle of your, how your legs come into your hips. And it moves the way that the rectum is situated so that it's a little easier to pass the stool from the rectum. And it really is helpful for some people. So you can get them, they're little plastic things to put next to your toilet. And along with mobility and positioning, making sure somebody's getting moved around. If they're not mobile, they need to be moved around quite a bit. They need to get up and moving, just like us who sit in front of the computer all day. We need to get up and walk around. Treating medical causes. We probably don't do enough of this, especially in this population, because we want to, again, blame it on something else. Oh, they don't eat enough. They don't do enough. You still, like anyone else would, need to make sure you don't have diabetes, thyroid problems, or bowel cancers, which do happen in everyone, including people with IDD. And so we can't ignore the possibility if someone's having new severe constipation out of the blue. So what do you do when you do have a problem and you've done your prevention and you still are, having trouble? This, we're getting into the mode of treatment. There is such a thing as bowel retraining. And that is if you work with anyone who does behavior plans, this is something that a person who does behavior management can help with, or you can Google it and learn about it. But essentially, it's trying to retrain the bowel to remember its sort of knee-jerk reaction, which is to release the bowel movement after you eat or when it's too full. And sometimes it's just forgotten. So by relaxing, sitting regularly, allowing the body to remember how it's supposed to work again, sometimes you get improvement just from that. That can be difficult because it involves, again, behavior change. And then there's medications, of course. There's really I like to think of it as two different classes of medications for bowel movements. One is the stool softeners, which we call the mush. Docusate, which is also called Colace, is the most common one. I'm sure you've all heard of it. It makes stool soft. Sometimes that's enough. Usually it's not, because if you have soft stool, doesn't mean it's going to come out any easier. It might still just be stuck in there. PEG stands for polyethylene glycol. That's the generic name for Miralax. So Miralax is also now known as a bunch of other things because it's generic, but essentially it's a powder that you mix with a liquid. And in small doses, it's more of a mush. It's more of a stool softener. As you increase the dose, it becomes more of a stimulant laxative, which is the next line on here. We call that the push. So that's the thing that makes your bowels want to move stool through. That again, at higher doses, that would be the Miralax. There's a medication called Senna or Senecot, Bisacodyl, which is Dulcolax, magnesium in lots of different forms. Probably the most powerful one is the magnesium citrate you can buy in a bottle. And then lactulose, which is a really sweet liquid. Those all cause your bowels to move, and they're called stimulant laxatives. They can cause cramping and some discomfort. They usually cause a bowel movement pretty quickly. And they're not always the thing you want to be on every day, but they certainly are a method to act when needed, essentially, as needed kind of thing. And then if things are really not improving, or you've got a real blockage that isn't moving, which sometimes happens. I mean, you get people, they cannot get this bowel movement out. Then you have to have an enema, which I'm sure you're familiar with. And there's lots of different types of enemas. You can buy them over the counter. You can create your own. That's something you'd want to talk to your medical provider about. Suppositories, which are little like melting tablets that get placed into the rectum. And then there's something called disimpaction, which if you've ever had to do it, is not pleasant, but it can make a huge difference, which is getting the bowel out of the way. That's sort of from least invasive to most invasive methods of dealing with constipation. Hopefully you don't have to get all the way to the bottom, but we'll move on to the next slide and we'll talk about the plans. Okay, first we need to talk about poop. At my house, we talk about poop all day long. It's just one of those things. It's like life, and we all need to know what's going on with our daughter's poop. If we don't talk about poop, we're in trouble, because we could end up with poop all over the floor later, or a lot of discomfort and misery. So this is a very well-known chart of how to describe poop and how to determine what's going on based on what it looks like. Right there in the middle, the sausage poop is the ideal type of poop. If you've got rabbit pellet poop, you're in trouble. But remember too, that if you've got liquid poop, that's not good either. And that doesn't necessarily mean that you're not constipated. The reason I show you this is to also move to the next slide, which is to talk about bowel plans. So everyone should have a bowel action plan. What that means is they are constantly communicating and recording what's going on with bowel movements in someone who has this risk, and have a goal. The ideal goal, now everyone's different, and again, this should be decided between you and your medical provider, but an easy to pass bowel movement every 2 to 3 days. Having a stepwise plan so you know where you are. Like, today is a green day because we had a bowel movement yesterday, or we had a bowel movement today and it was easy to pass. After, say, 2 days, you start getting in the yellow zone. Well, what do you do when you're in yellow zone? Maybe that means you add something, you do something different. Your green days may mean you're not doing anything different, or it may mean you're taking Miralax every day, for instance. Everybody's different. Red might mean, oh gosh, we're at day 3, or I can tell something's going on, or the person's saying my belly hurts. Red may mean one of those stimulant laxatives. It may mean an enema. It depends on what's going on. But having this plan that everyone knows and everyone communicates means that there is no surprise on Saturday where you learn, oh my, there's been no bowel movement in a week. And then you're behind the 8 ball. So, and then of course, if you're not getting the responses you expect at yellow, when you act at green, yellow, red, especially red, then you need to get in contact with your medical provider and say, hey, we've done everything on this plan, it's not working. And then if you see any of these things we call red flags, which means blood from mixed in with the bowel movements, fever, pain, those are things that you do not wait. You just get evaluation. That means urgent care or whatever it means. But calling your doctor is always a good idea too at that point. All right, I think we're moving on. So we're going to go to the top of the GI tract now. That was the bottom. Gastroesophageal reflux. We all probably have experienced this. It's also called GERD. It's when acid goes up into the esophagus, which is the tube that takes your food from your mouth down to your stomach. It can be totally silent. You may not know you have it. But most of the time there's some symptoms. The typical symptoms are that burning sensation you feel in your chest, or that acidy taste in your mouth. Sometimes there's pain. Some people actually, because the reflux of acid goes all the way up and gets down close to their airway, they might even get hoarse or wheeze or cough, especially at night. And this is not unusual that people are evaluated for asthma and it turns out they have reflux because it's causing their airways to get irritated, especially when they're lying down at night. A constant sort of sense of regurgitation of food contents is also from GERD. And then erosion of your teeth in the back, especially the back teeth, because of acid coming up back there. We know it's made worse by certain medications, by being overweight, by eating a diet that causes more acid or causes more reflux. Smoking is just terrible for this. So if you're a smoker, definitely that'll make a big difference to quit smoking. Lying down after you eat definitely makes things worse. Being in a relaxing, reclining position is always going to make it worse. So if someone's, say, in a wheelchair, having them sit up straight makes a big difference. Wearing a tight belt. And then there's something called a hiatal hernia, which is basically where your stomach is kind of high up in your abdomen and even coming somewhat up into your lungs. And that's just a, unfortunately, a setup for reflux. And some people have that. They're just born with it. Sometimes that's related to certain syndromes too, which are associated with IDD. So something we see a little more frequently in this population. And then over time, when you've got all this acid coming up, it can erode the tissue in your esophagus. And that can lead to problems with swallowing, bleeding, and eventually can lead to cancer. And then also, unfortunately, can add to the aspiration risk, which is next on our list of the fatal 5. So I think we're moving on. Oh, well, if you want to see a picture, basically, the esophagus is that long tube. It leads to the stomach. We have this nice little sphincter, which is a ring of muscle, which is supposed to close off and not allow the acid to come back up. It just doesn't always work great. Unfortunately, if your stomach's too full or if you're lying down, there's room for that acid to come back up. Okay, next slide. All right, I've sort of reiterated this stuff as I went through before, but it's sitting up, losing weight, raising the head of the bed. That's a pretty easy thing to do. You can put something under the top of the mattress, especially if reflux is mostly at night. These are the diet changes that are generally recommended: getting rid of spicy, fatty, fried foods and caffeine, all the yummy things in life, right? Not smoking, wearing loose clothing. The typical treatments for reflux, you're probably all aware of. There's the proton pump inhibitors class, which is the omeprazole and pantoprazole. That's Prilosec and all of its cousins. They used to be prescription, but now they're over the counter. And then H2 blockers are what we had before PPIs, and those are the ones that just block acid. Proton pump inhibitors stop you from creating acid in the first place, whereas the H2 blockers block the acid after it's made. That's Zantac, Pepcid. So we have sort of two classes. The proton pump inhibitors are the ones that most people are using now. I will tell you, you can also use antacids, but those are kind of after the fact, and a lot of times damage is done. So if you've got reflux and you take Tums, or you've got reflux and you take Mylanta, it might help your pain, but it's not necessarily stopping the acid or the reflux. If you've had a good trial of these medications and you've done a bunch of lifestyle things and you're still having trouble, then endoscopy, which is where they put a tube down and look, is often needed. Especially if you're having bleeding or difficulty swallowing, to make sure there's not a problem down there that needs to be treated. And then there's a surgery that can treat reflux. We used to do a lot more of it before the PPIs came out, but now it's not quite as necessary, thank goodness. But some of our folks need it because there's just no other way to fix this problem. And sometimes, especially if they have a hiatal hernia or some other structural reason why it's not getting better. All righty, we move on. So now we're going to get to aspiration. I put these in this order because they all kind of relate to each other. So as you can see, the reflux can lead to aspiration. That's one of the risks. Unfortunately, aspiration is the most common cause of death in institutional settings. I mentioned the bowel obstruction, but aspiration is the one that unfortunately people die of more frequently. And it also happens more as you get older too. So again, like GERD, it can be silent or symptomatic. So someone can be having aspiration and we don't necessarily know it. Or you'll notice that when they eat or drink, they cough, or they look like, or they choke more often. That's often a symptom of aspiration. It's related to the GERD, like I mentioned. It's also related to positioning, again, like GERD. And then what we see a lot of times with our folks with IDD is it's also related to eating behaviors. If you eat too fast, if you don't chew your food all the way, sometimes things just go down the wrong tube, which is what aspiration is. It's also more common if you have a neurodevelopmental disorder that has affected your nerve functioning such that your gag reflex doesn't work as well. And we all are aware of the gag reflex. Some people have a lot more gag reflex than others. And sometimes if you have a problem with nerves and brain function, you may not have that gag reflex that is protective. And you also may have some difficulty swallowing, because swallowing is a complex neurologic and muscular movement when you think about it. Everything has to work really well together to swallow. And, you know, sometimes I'm sure you've all experienced, it's hard to swallow. Like when someone asks you to swallow, you have to think hard about, you know, it doesn't always feel natural. How do you figure out somebody's aspirating? The most common way to find out is to do what's called a swallowing study. That can be done with barium and x-rays, or now most of the time it's done with fluoroscopy, where you swallow something and they're watching it go down the whole time. It's really cool to watch. And then they can actually see the fluid come back up again, or even go down the wrong way. Also by x-ray, and I'll show you that in just a minute. Once someone has had an aspiration pneumonia, it can be very obvious on an x-ray. And then if you've ever had this happen to you, you know, people who've had a stroke or people who are in the hospital with an aspiration pneumonia, the speech and language pathologists are well trained to do what they call bedside evaluations, where they don't even need an x-ray or fluoroscopy. They'll just watch you swallow, and they can look how your tongue works, how the back of your throat works, and figure out that you're having trouble. The reason aspiration is an issue is the biggest problem it causes is aspiration pneumonia, but it also can lead to choking and death. We do have some treatments, changing diet, you know, chopping up food into smaller pieces, thickening liquids, keeping people upright when they eat and after they eat, watching them eat to try to keep them from taking too big of bites or too frequent bites. And since I mentioned GERD's related, treating GERD is important. And then you'll have seen people who get G-tubes because of aspiration. That does happen. I will say that the evidence for whether that really totally prevents aspiration is not great, that you can still have aspiration even with a G-tube, unfortunately. So it needs to be considered if it's really the right answer. So next you'll see, I think it's the x-ray. No, it's this one. So just so you know the anatomy a little bit, if you put your hand on your neck, the thing that you feel first is your airway. It's your trachea and windpipe. That's where you're breathing from. But right behind that is your esophagus. And they're right next to each other, and they go down the same way. So when you eat food, you're headed down the same path. And there's this little flap there that's supposed to block the airway from getting anything in it. But sometimes it doesn't happen. I'm sure you've all experienced that. And unfortunately, then the food or the liquid goes down the wrong pipe and ends up in the trachea or down into the lungs. So the next one is the x-ray, I think, finally. There you go. So when that food or liquid goes down that airway, you see that dark stripe down the middle. So it's going down that airway. The first thing that happens is the right bronchus, which is the right pipe that goes to the right lung, comes off first. So most of the time, the fluid goes on the right. So when we see an pneumonia like this, which is all that's marked here, all of that would be black normally. That's all pneumonia. That's all inflammation and liquid and gunk in there. So most of the time, a right middle lobe pneumonia, which is what this is from aspiration, because it's just classic. So if you've got that, you've probably got aspiration, just because of the way the anatomy works, and that's where things fall or go into when you aspirate. So next slide. So we're moving on through the fatal 5 to dehydration. About 60% of our body is water, and it's up to us to keep that water full. For folks who can't swallow well, they can't indicate they're thirsty, they can't walk to go get fluid, they sweat more. And that unfortunately happens with some folks with what we call autonomic problems. So maybe the way that their brain controls heat doesn't work well. Or if they have kidney issues where their kidneys don't work as well, because your kidneys are what control your fluid volume. So if you or I, who have normal kidneys, suddenly couldn't drink for 8 hours, our kidneys would know to hold on to fluid. Whereas other people's kidneys may not. They may keep dumping fluid even if you're dehydrated. Dehydration is particularly dangerous if you're on certain medications, and that would be antipsychotic medications, because sometimes they affect your heat regulation. Lithium, because lithium can be dangerous for your kidneys if you're dehydrated. And you can have a toxic level of lithium if you don't drink enough. Diuretics, like we mentioned, make you dehydrated if you don't keep up with drinking the fluid that you need, because they make you pee more fluid out. And then NSAIDs, that stands for non-steroidal anti-inflammatory drugs. And those are like ibuprofen or naproxen. They can also hurt your kidneys if you're dehydrated. So very important if you're on any of these medications regularly that you drink plenty of fluid and don't get dehydrated. Dehydration is also worsened in settings where we restrict somebody's fluid, which you might think is a good idea, and sometimes it is. For people who are having bedwetting is a good example. We sometimes restrict their fluids. Well, you got to be very careful that you're not causing also dehydration by doing that, especially in summer months when it's hot. If somebody has a fever, if somebody's having diarrhea or vomiting, they have to have more fluid. As we talked about already, being dehydrated makes you constipated, and it can increase that obstruction risk. And the symptoms are usually, you probably all had this, and so you know, but medically speaking, if you're doing the medical evaluation, you're looking for low blood pressure, high heart rate, and then people will complain that their head hurts or they're dizzy, or sometimes people just fall, and then we figure out they're dehydrated because they were too dizzy. Dehydration can lead to seizures because when you don't have the right fluid, sometimes your electrolytes get off balance. And if your sodium, potassium, or magnesium are abnormal, it can lead to a seizure. So a lot of things, it's like a bad cascade here. Next slide. So how do we prevent dehydration? And it's an input-output thing. Got to make sure you're putting enough in, got to look and see what you're getting out. So the average person is 2 liters a day. And, you know, I don't know anybody who's average. So we all probably need more or less than that. And we have to figure that out for ourselves. So if someone has IDD and they are on medications that make them more dehydrated, they may need twice as much. And then one of the ways you can figure out if somebody's dehydrated is by tracking their output. Theoretically, your output and your input should be equal. I don't know too many people who measure their output, but you can look at the volume, you can look at by just amount, and generally speaking, or you can look at the color, which is a little easier. Urine should be light yellow, not dark orange, definitely not brown. If you have somebody who's having really hard stools all of a sudden, that's also a sign that they're probably dehydrated. This is another one, just like bowel movements, that how much people are drinking needs to be communicated. If the person that we're talking about can't communicate it, then the caregivers need to be keeping track. Now, providing constant access to fluids is important, especially if somebody's not mobile or if they don't have access otherwise. Now, there are situations where that's not okay. So I'm not saying it's always okay. There are people who will overdrink. That's rare. So I didn't want you to think that anybody and everybody should have constant access to fluids. There might be a few that don't, but most people need their own access to fluids. And then if somebody doesn't like to drink a lot, just encouraging them to have small frequent sips. That can add up. It also, when they're eating, that can really help prevent choking. So every time you take a bite, you have a sip of something. What I found helpful is to have special bottles, a bottle that people like. I like my own water bottle. Pick it out yourself, take somebody to go pick it out, whatever color they like, and then talk about how many of those they're going to finish by the end of the day. If someone doesn't like water, there are tons of ways to add flavor to the water without adding sugar. Ideally, water is best without the sugar. So you can add fruit, you can add some of these little flavor drops or flavor packets. You can also add more foods that have high water content. So fruits, soups, even dairy products like yogurt and ice cream will provide a little bit of fluid. And then probably goes without saying, but caffeine can be somewhat dehydrating. It does provide some liquid, but not as much as you think. And then diuretics make you pee out too much. So trying to avoid those if you don't need them. Alrighty, next one. Okay, seizures. So I think this is our last of the fatal 5. A seizure is a sudden, uncontrolled electrical activity in the brain. It causes physical, behavioral, and neurologic changes, just to get everybody on the same page. There's several things that can cause someone to have a seizure. If a drug level is too high, or if they've been on a drug and they stop it, certain drugs can do that. Alcohol can do that. A class of drugs called benzos, which is like Valium, Klonopin. If you stop those without weaning down, you can have a seizure. I already mentioned electrolyte abnormalities can cause that. So sodium, magnesium, calcium problems can all cause seizures. Brain tumors, very rare, but are a cause of seizures. There are certain psychiatric issues that trigger seizures. Those are not epileptic seizures. Those are a different type of seizures, but they look like epileptic seizures, so it's important to mention that. And then there's epilepsy, which is the primary cause of seizures. So what is epilepsy? Technically, epilepsy is diagnosed when you've had 2 or more seizures at least 24 hours apart. So not like a seizure and then 15 minutes later another seizure. The 2 or more seizures far apart with no cause after an evaluation for causes. So all those things I just mentioned were ruled out. And then people will say you have epilepsy. Epilepsy, unfortunately, tends to be more common in people with certain syndromes or people with autism. And the reason we care about seizures, nobody likes them, they're not pleasant, but also the biggest reason is because they are related to sudden death. And that is specifically something called sudden unexplained death in epilepsy, or SUDEP, which is unfortunately more common than I realized until I had a child with epilepsy and started reading about this. It occurs in 1 in 1,000 people with epilepsy each year, and 1 in 150 of the people who have uncontrolled tonic-clonic epilepsy. So that's the person who's still having generalized seizures, despite the fact that they're on medications, despite the, everything that's been done, and it's just what we would call uncontrolled generalized tonic-clonic epilepsy. Used to be called grand mal type seizures. SUDEP occurs more commonly at nighttime during sleep. No one's quite sure what causes this or why. They just know that certain people are at higher risk based on their seizures. So it's good to know about this. So what can we do? Next slide. So just so you know, the goal is to have as few seizures as possible. That's why we prescribe seizure medications. Sometimes people wonder, do I really have to take all these seizure medications? Well, we know that if your seizures are under better control, you're less likely to die. So that means taking the meds that are prescribed regularly. It also means trying to figure out why your seizures happen. That's not always easy. There's not always an answer, but looking at, what happened before, what's been going on, are they related, often related to illnesses or stresses or any number of things, and then trying to avoid those if you can. Having a seizure plan. This is going to sound familiar now. We talked about bowel plan, we talked about hydration plan. So seizure plan, you've probably seen these. It's a plan in writing for how you address it when someone has a seizure. And that's sort of knowing a little bit about seizure first aid, which is you do not put things in people's mouths. You do not, you try to get them comfortable, put a pillow under their head, turn them on their side so that they don't aspirate. We already talked about aspiration, but the seizure is another risk for aspiration. And then giving them emergency medications if that's what's been prescribed by your physician. And that would be prescribed and explained to you. There's both a rectal diastat, which is Valium, and there's a nasal spray that's come out in the last few years, which is a version of midazolam or Versed. They have their pros and cons, but those are the emergency medications. And they're usually used when someone's seizure is not going away after a certain amount of time, like 3 to 5 minutes. There are seizure warning devices. They're still a little bit controversial as to how good they are, but I think they're getting better, like most of technology. Some of them are wristwatches, and then they may be helpful at night to try to alert people. Having cameras in a room or shared bedrooms because of the increased risk at night. And of course, you have to weigh that with someone's privacy issues and their rights. And then talking with your medical provider to discuss escalating the treatment if seizures are uncontrolled. So that means you don't just say, oh, well, we've tried it, but it's not working, but that's just how it is. There are more options. There are more drugs every day. So do not, feel totally comfortable saying, I think I'm worried that these seizures are still happening. What else can we do? Next slide. Oh, there was one more. I'm sorry. So sepsis. Sepsis is when bacteria goes through your bloodstream and can cause you to die really quickly. It happens more in the old, the young, people with immune problems. The symptoms are usually fever, low blood pressure, chills. You look very sick very quickly. Usually it comes from some other source of the bacteria. So UTI, pneumonia, skin, anywhere you could have a bacterial infection. But you don't always see those. Those can be hidden. Maybe you didn't even know that was happening until they look deathly ill. And the key to this is to act fast, get people care. All right, I think we're finally near the end. There we go. This is the key I wanted to make sure we got to. I would like to empower everyone to feel like they can navigate this very complex medical system. And it's particularly hard when you have to deal with complex ongoing issues that maybe your medical providers don't even understand. So here's some things that I've learned personally and as a physician that are helpful. Have a notebook where you keep the medical information, the medications, the medical history. It's out of your head when you get to the doctor's office, and you will not have enough time. Bring it everywhere with you and have your questions ready to go. Always know and how to express, and everyone should know who works with someone with IDD, what their baseline status is. And what I mean by that is, on a good day, when things are going well, how does this person act? What do they feel like? How do they communicate? And then as they do, if things change, you'll recognize that and you can explain that well. This is not where they usually are, because as a physician, you're seeing someone, you have no idea, is that always how they look, or should I be worried about this? I always appreciate the fact that the person and their caretakers, their family members, they know best. And you should not be afraid to know that you know best. So don't be afraid to ask questions. You know this person. They know themselves. They need to know that. They need to hear that something is different, you're worried, and a good medical provider will understand, oh, well, if she's worried, I need to be worried. If you're not getting that, you need to ask for somebody else. Ask for a second opinion. If you're seeing a nurse practitioner, ask for their physician to come see you. A lot of times providers are rushed, and it is okay to ask several times the questions you need answered, and not to leave until you understand, what is the plan here? What do I need to come back for? What do I need to look for? What do I need to worry about? And if you think you can't remember it, which I would not be able to remember it either, is ask for it in writing. They should be able to give you a plan, including the warning signs and when to come back in writing. So feel free to, also reach out to partner staff if you have a care manager or other supports that I'm sure the folks here can tell you more about, because it's not easy to do this alone. It's a village. We all need help and support. And especially navigating the medical system, even if you didn't have IDD, it's a complex, major thing to navigate. All right, next step. I think we're about done. There you go. So these are just some websites that I found useful. I didn't want to put too many, but for various reasons, they all had different important things. And that's my girls when they were younger. I just love that picture because they're having such a good time together. The joy of children playing. So sorry, it took a long time. I didn't realize it was going to take so long, but I am open to questions and look forward to hearing what you have. Let's see. I only see one here, Beth. Should I just answer that one? Talk about GERD and the link to cancer. Okay, sure. So long-term GERD can lead to something called Barrett's esophagus, which is where the cells of the esophagus start to change and first become precancerous and then later cancerous. So that is a reason when someone doesn't get better with treatment of GERD and they've tried everything and it goes on and on and on to do that, that endoscopy, because they can go down, they can look with a light and they can take a piece of tissue biopsy and they can look for Barrett's esophagus and they can treat it before it becomes cancer. So that's the association.
Dr. Bartholomew, we have somebody who's raised their hand, so I am going to allow them to talk. Give me just a second. Okay, Mr. Vino, you can mute yourself.
Yes, thank you very much. Doctor, you talked about aspiration of food into the lungs, which causes pneumonia. How does the food come out? Is it just the body deals with it, or does it have to be surgically removed?
Well, it depends on how much of the substance that goes down into the lungs. Most of the time, the lungs deal with it. It becomes this inflamed area that it just takes care of over time, kind of like healing a wound. But if it's a giant piece of hot dog or something like that, and it's crammed in the bronchus, they will go down and get it sometimes with the bronchoscopy and grab it with, what looks like little tweezers and pull them out. But by the time it's gotten far into the lung, usually it's taken care of there. Now, it can lead to abscess formation because of too much inflammation, and it certainly leads to pneumonia, which is an infection. So that's why you have to have treatment, usually even with IV antibiotics sometimes.
Thank you very much.
You're welcome. So I see something about sleep and autism and trigger for seizures. Yes, I should have mentioned that actually. Lack of sleep is probably the #1 trigger for seizures. In fact, in order to try to get somebody to unfortunately have a seizure when you're doing an EEG, you often ask them not to sleep because you're trying to see seizure activity on their EEG. So yes, sleeping well is very, very important. As far as the relationship to autism, I'm not sure we know exactly why autism has a higher association of epilepsy. I'm sure that it's partly due to autism's association with certain genetic markers, and that epilepsy also goes along with those genetic markers. I also would say that many of kids with autism or adults with autism do not sleep well, and they may not get the deep sleep that they need, so that may contribute. A number of different multifactorial reasons why autism is related to seizures that we're still trying to understand. Psychiatric symptoms that cause seizures. So there's, I was trying not to go too deep into this because it's a talk all in of itself, but there's something called psychogenic non-epileptiform seizures. And that is when people have seizures that look just like epilepsy, but they are triggered primarily by traumatic events, psychiatric disorders, and oftentimes we can't tell the difference unless we do what we call video EEG monitoring, where someone's put on an EEG and watched on a video camera. And then when they have one of those spells, the EEG shows that there's not necessarily electrical changes in the brain. That is not to say that this person is faking. I don't want anyone to think that, because what we know is that is absolutely not true. Oftentimes it's a sort of a disassociative experience where it's sort of a physiologic way of dealing with a psychiatric issue. But it just adds more complexity to how to evaluate and deal with seizures. That's also a possibility.
Okay, we had someone that submitted a question prior to the webinar, and it is, my person of concern is a slow learner and morbidly obese. Differing opinions on how to deal with her weight. Planned appointment soon to see a gastric doctor, but concerned this doctor will not be prepared to also deal with her mental capacity. And do you have any thoughts about that?
Yes, that's a tough situation and not unusual, unfortunately. Like I said, our population with folks with IDD do have higher rates of obesity. I think, what it will take is someone, it may take more than one visit to talk about the possibilities and what will work best for your person, because everybody's so different. Most people want to start with diet, exercise, maybe even medications before they move on to bariatric type surgeries. I think this is where doctors sometimes feel uncomfortable because they don't know how to manage someone who has a different way of interacting than what they're used to. They don't know how to manage behaviors very well. So pre-planning for that, if you do decide to do surgeries, talk about how it would go best. Would it be best as an outpatient surgery, inpatient surgery? Can you get some behavior support while they're in the hospital? Can you have behavior support people talk to the physicians that are going to be doing the operation? I think oftentimes we tend to just say, oh, well, she or he will never be able to do that because they just won't be able to handle it, rather than actually try to talk through how to problem solve around these things. Everybody deserves, equitable healthcare. And just by saying, she has maybe a learning disability, so therefore she shouldn't get what everybody else gets, tends to make me angry. But finding someone who can advocate for you, if it's your primary care physician, might be helpful. If it's another family member, hope that helps.
Thank you. There was another one, is that the calcified pieces that are coughed up?
Maybe. I'd have to see them. I don't know. Perhaps. I think people cough up as much as they can, and unless it's down too far. So, yeah.
And do you think seizure therapy dogs are effective?
I think there's a lot of benefit to them. I'm not sure they prevent seizures, but they alert people to seizures earlier so that they can be taken out of dangerous situations, get attention quicker, that kind of thing. It'd be nice if we had evidence that they prevent more seizures. Now, maybe because maybe they help people feel less stressed. I'd be curious to know that, but I don't think we have that evidence yet. Certainly seems like a great idea to me. There's even autism support dogs and they're learning to do so many things with support dogs.
Thank you. Did you, by chance, I was pulling up the questions that were previously submitted. Did you address the question about the psychiatric symptoms?
Yes.
Okay, perfect. If anybody else has any questions, please feel free to go ahead and put them in the chat or raise your hand, and I will be more than happy to unmute you. Well, we are coming close to the end of our time, and I want to thank you, Dr. Bartholomew, for sharing your time with us today and giving us this great information. We sure do appreciate you joining us.
Well, thank you. I enjoyed it. Thank you so much for having me.
And also, if you have any more questions, last call for questions. Okay, feel free to join us next month. We will be having Melissa share with us about pregnancy and addiction. So we look forward to hearing more about that. So please join us, register, and we will be sending out more communications about that. So thank you so much, and you all have a fantastic day.
Thanks, y'all.
Thank you.